Hey everyone, and thanks for taking a few minutes to walk through this Guide Academy session with me. I'm Ali Bagai, Chief Clinical Operations Officer here at Guide Anesthesia. Today we're looking at how to approach the patient with a BMI above 45 and especially above 50 when they're scheduled for elective surgery in an ASC. Before we dig in, I want to frame this around evidence-based practice. Our decisions should be grounded in the best available research, not just habit or what feels safest at first glance. That does not mean we ignore experience. It means our judgment should be informed with the latest evidence. This is focused on ASCs, but the same principles apply to other resource-limited environments, including specialty hospitals. The central question is not just what is the BMI, it's whether the patient, procedure, anesthetic, and facility safely match. I want to start off by acknowledging that some of you may disagree with where this evidence lands. If your instinct is support a hard BMI cutoff, that concern comes from the right place. It's rooted in patient safety. A hard cutoff feels clear. It's easy to explain in a chart review. It gives the team a bright line. I respect that instinct. And I want to be clear, the risk at the highest BMIs is real. Gupta and colleagues looked at 1.4 million non-bariatric general surgery cases and showed adjusted odds of mortality of 2.31 for BMI 50 to 59.9 and 2.63 for BMI 60 and above. That is a real signal. The case I am making is not that BMI does not matter. BMI matters. The question is whether BMI alone is strong enough to function as an exclusion criterion, or whether the right response to that risk is a more rigorous, individualized workup. The literature lands firmly on the second, that BMI alone should not be an exclusion criteria. Let us put a patient in front of us. She is 48 years old, scheduled for an elective bunionectomy at an ASC. This is a short, low-stress procedure that is very compatible with regional anesthesia or MAC using a block. Her BMI is 52. That number gets our attention, and it should. But now look at the rest of the patient. No history of sleep apnea, no cardiac history, Malampati 1, neck circumference 37 centimeters, plant anesthetic is regional or MAC. The question is, should she be turned away based on the BMI alone? I'm not asking whether BMI 52 deserves a closer look. It does. I'm asking whether the number by itself is enough to exclude her when the rest of the risk profile is favorable. Hold on to this patient because we're going to come back to her later. There are three things I want this session to accomplish. First, to show why major guidelines do not support hard BMI cutoffs as the sole basis for surgical eligibility. Across multiple specialties, the direction is towards individualized assessment and shared decision making. Second, to identify what actually predicts perioperative complications in patients with obesity. The strongest signals are not BMI by itself. They are comorbidity burdens, OSA and OHS, airway anatomy, cardiopulmonary reserve, procedure type, and anesthetic technique. Third, to give us a practical structure, it is not enough to say, do an individualized assessment. We need a repeatable approach that can be defended clinically and operationally. The goal is to shift our thinking from, is the BMI too high, to, can this specific patient be safely managed at this specific facility for this specific procedure. When we look across major guidelines and specialty statements, the message is very consistent. Assess the patient, not the number. The American College of Rheumatology and the AAHKS discourage rigid BMI thresholds and recommend shared decision making. ACOG Committee Opinion 763 describes refusal of care based only on an arbitrary BMI cutoff as unethical. ASRM does not set a society-wide BMI threshold. The National Institute for Health and Care Excellence in the UK advises against BMI-based restrictions for joint replacement. The AHA approach focuses on actual physiologic contraindications rather than BMI alone. What is also striking is that even among the surgeons who do enforce cutoffs, there's no consensus on what the number should be. In 2021, Sherman surveyed AAHKS members. About half use BMI 40, a quarter use BMI 45, and only 8.3 have a cutoff at 50. 5 major societies say no hard cutoff, and the practicing field cannot agree on a number. The next question is how well BMI performs as a screening test. Giori and colleagues looked at more than 27,000 VA total joint replacements. At a BMI cutoff of 40, about 14 complication-free surgeries would have been denied for every 1 complication that was avoided. BMI greater than 40 catches complications at roughly 6.74%. Random selection catches them at 5%. So basically, BMI greater than 40 barely beats baseline risk for complication. Kwasny and colleagues evaluated BMI as a prognostic test and found an area under the curve of 0.51 to 0.56. That is barely better than chance. The false positive rate was 96 to 97%. That matters operationally. If we use BMI alone as a hard exclusion, almost all of the patients we exclude would not have had the complication we were trying to prevent. This does not mean BMI is irrelevant. It means BMI is a poor standalone decision tool. It should trigger a better assessment, not end one altogether. The literature points us towards the real signal, which is comorbidities and procedure type. Yamin and colleagues, they studied 239,000 plastic surgery patients. It showed that in patients without comorbidities, BMI below 35 did not significantly raise complication risk. When comorbidities were present, risk began to rise at a BMI of 30. The same BMI can mean very different things on the patient's physiology. Sood and colleagues looked across 16 procedures and found that BMI 18.5 to 40 had similar complications and mortality, while morbid obesity carried elevated risk. That supports targeted optimization rather than blanket exclusion. Madsen and colleagues, in 5.57 million patients across 9 specialties, found that obesity raised odds of infection, VTE, and renal complications. But mortality, pulmonary, cardiac, bleeding, and readmission odds were not elevated, except in class 3 obesity. The point is that the risk is selective, not uniform, and it depends heavily on the patient and the procedure. There is a second argument against hard cutoffs that is often missed, and it's one that ACOG names explicitly. Hard cutoffs do not fall equally. Kurender and colleagues in a study of nearly 400,000 patients from NSQIP, plus the National Health and Nutrition Survey, showed that at every BMI cutoff studied, from 30 all the way to 50, female patients and black patients were disproportionately ineligible. Wang and colleagues found the same pattern in 21,000 older adults. Inflexible cutoffs disproportionately reduce surgical eligibility for non-Hispanic black patients, women, and lower socioeconomic status patients. Kulkarni and colleagues confirmed the pattern for shoulder arthroplasty, and McLaughlin and colleagues in a 500,000 patient interrupted time series from England showed that when localities introduced strict BMI policies, NHS surgery rates dropped, and the proportion of privately funded, more affluent patients went up. The authors recommended these policies be discontinued. This is the equity dimension of the argument. When a screening test is this weak, the disparities it creates are not justified by the safety it provides. We should replace BMI with something better. OSA and OHS are where a lot of practical screening happens. Stop bang is a validated tool. A score of 3 or higher is 93% sensitive for moderate to severe OSA and essentially captures severe OSA. Saban and colleagues in 375,000 patients found that OSA nearly doubled the odds of same-day admission after ambulatory surgery, with an odds ratio of 1.94. But the condition that should really get our attention is obesity hypoventilation syndrome. OHS is underdiagnosed, more common at the highest BMIs, and linked to difficult intubation, post-op respiratory failure, and opioid-induced respiratory depression. The screen should be structured. Step 1 is to screen with stop bang together with a serum bicarb and resting room air O2 set. Stop bang of 3 or higher with bicarbonate of 28 or above, or room air SpO2 below 95 should raise concern. Step 2 is to confirm with an arterial blood gas if either screen is positive. That is much more meaningful than BMI alone because it identifies the physiology that actually drives the risk. The airway assessment also needs to be specific. Neck circumference above 42 centimeters is a practical screening threshold, but the underlying data are more specific. Ryad and colleagues in a prospective study of 104 morbidly obese patients found that neck circumference greater than 42 centimeters and BMI greater than 50 were independent predictors of difficult intubation. Male sex and BMI greater than 50 were independent predictors of difficult mask ventilation. That is the most important caveat in this presentation. The population level evidence shows BMI is a weak predictor on its own, but the airway specific data show that BMI greater than 50 carries a real distinct airway signal. We honor that with the workup, not with blanket exclusion. The ASA difficult airway guidance reminds us that airway assessment should be multivariate. Malampati, mouth opening, thyromental distance, neck circumference, prior difficult airway, and the planned anesthetic all matter. And the anesthetic plan is part of the risk profile. Regional anesthesia can remove or substantially reduce the airway concern that drives many cutoff arguments. Let us pause and compare two patients. Same procedure, same facility. Patient 1 has a BMI of 52, Malampati 1, neck circumference 38, no history of difficult intubation. Patient 2 has a BMI of 44, Malampati 4, neck circumference 48 centimeters, and a history of failed intubation. If we use only BMI, we would be more concerned about patient 1, but the airway data tells us patient 2 is the higher risk by a wide margin. That is the core problem with hard cutoffs. A number can trigger a review, but it cannot complete the review. It cannot tell us whether the airway is manageable, whether regional anesthesia is feasible, whether the patient has OHS, whether the facility has the right equipment, or whether transfer to a higher level of care is realistic. The number cannot tell you. The patient can. Now let us look at evidence that is closer to the ASC environment. Haj Mohammed and his colleagues analyzed more than 660,000 outpatient surgeries and found no significant difference in 72-hour post-operative complications between patients with a BMI greater than 50 or those with a BMI of 40 to 50. The authors explicitly concluded that super morbid obese patients should not be excluded from outpatient procedures based on a BMI cutoff alone. ASC bariatric guidelines provide an important counterpoint. They permit ASC bariatric surgery up to a BMI of 55 in males and 60 in females, but only under specific conditions: no organ failure, no significant cardiopulmonary impairment, and ambulatory status. Even for bariatric surgery, which is being done specifically because of the patient's weight, the decision is not BMI alone. Wong and colleagues and Warender and colleagues had the same theme in different ASC populations with careful selection. BMI alone should not function as an absolute contraindication. This is not permission to proceed with everyone. It is evidence that selection should be structured and individualized. This curve is helpful as a reminder that risk is not a straight line. Bald and colleagues found a U-shaped relationship between BMI and adverse discharge, meaning discharge to a setting other than independent living. Overweight and class 1 obesity were associated with modestly lower risk than the reference point. At BMI 50, risk was elevated with an adjusted risk ratio of 1.36. There is an important caveat. This was non-cardiac, non-bariatric, non-ambulatory surgery cohort. So we should not directly apply the absolute risk ratio to every ASC patient. But the shape of the relationship matters. BMI does not have to behave like a simple on-off switch. Risk increases at the high end, and we should respect that. But there's no evidence that a single number creates a universal step function where everyone above that number is unsafe and everyone below that number is safe. That is why a structured assessment is better medicine than a hard cutoff. This is the structured alternative, 6 steps. The first 5 happen during PAT or chart review before the day of surgery. Step 1, OSA and OHS screening, stop bang, serum bicarb, room air O2 sat, and CPAP use. Step 2, cardiopulmonary review, pulmonary hypertension, RV dysfunction, functional capacity. Step 3, metabolic and comorbidity assessment, A1C, hypertension, lipids, GLP timing, and VTE risk. Step 4, anesthetic technique. Is regional feasible? If general is needed, what is the airway plan and the backup? Step 5, the facility readiness, table limits, equipment, staffing, difficult airway resources, transfer logistics. And step 6 is the bedside multivariate airway exam on the day of surgery. That workflow turns BMI from a hard stop into a trigger for a structured, defensible review. The question becomes, can this specific patient be safely managed at this specific facility for this specific procedure? This algorithm puts the same process onto one page. We start with a patient with a BMI greater than or equal to 45 scheduled for elective surgery at an ASC. I would also apply this framework to specialty hospitals or other resource-limited settings where backup resources may be constrained. Instead of stopping at the BMI, the pathway moves through a structured preoperative assessment, OSA and OHS screening, airway assessment, cardiopulmonary review, metabolic or comorbidity assessment. Then we plan the anesthetic technique. Can regional anesthesia be used? If regional is feasible, the risk discussion changes significantly. If general anesthesia is required, especially with a difficult airway or poor pulmonary reserve, the threshold for a higher acuity setting should be lower. Finally, we ask whether high-risk red flags are present. If yes, refer to a higher acuity setting. If no, proceed at the ASC or specialty hospital with the right plan, optimization, and facility readiness. The pathway shifts the question from, is the BMI too high, to, can this patient be safely managed here? So let's come back to our patient. Case A is the BMI 52 patient scheduled for an elective bunionectomy. No OSA, no cardiac history, Malampati 1, neck circumference 37, regional or MAC is the plan. Her BMI triggered a careful assessment, but the actual risk factors are favorable. She is very likely appropriate for an ASC. Case B has a lower BMI of 44, but the risk profile is very different. She requires general anesthesia. She has untreated severe OSA with suspected OHS. Her resting O2 sat is in the 90 to 92% range. She likely has pulmonary hypertension and RV strain. She's got a Malampati 4. She's got a big neck, difficult airway, and poor functional capacity. That patient is not refused at the ASC because of her BMI. She is referred to a higher level of care because multiple red flags exceed what a resource-limited setting may safely manage. That's the central takeaway. BMI is a data point, not a decision point. This is not about lowering standards, it's about raising them by matching the patient, the procedure, and the anesthetic, and the facility using the best available evidence. Thanks for taking the time. The full literature review with references can be found in the Guide Academy folder, and it's also linked in the description of this video. Just a couple last slides. These are the reference lists for everything that we covered. This one lists the guideline and position statement sources. They're all available with links in the article, that literature review. I encourage you to read the primary sources, especially Giori and Quansi on BMI's weakness as a screening test, and Yamin, Sood, and Madsen on why comorbidities and procedure type carry the actual risk signal. And then on this final slide here, ASC specific evidence, the OSA, OHS, and airway risk driven literature, and the equity and practice variability studies that underpin the disparities argument. Thank you again for working through this with me. The goal is to make sure that when we make these decisions for our patients, we are doing it from the strongest available evidence with the patient and procedure and facility in front of us, and not from just a number alone.